Good afternoon, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect welcoming you all for today's Mixed Bag webinar organized by Dr. Ritu Santwani ma'am. So let me introduce our moderator of today's webinar, Dr. Ritu ma'am. Ma'am has done MBBS, MD, FICOG, FIAOG, AMRCOG. Ma'am is the consultant, obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio, and infertility specialist. Ma'am is also a part of NUHS Singapore, co-founder of MAAM and board member of SWWC. I welcome you, ma'am.
Thank you, Sahiti. A warm welcome to all of my dear friends who have joined here today. Friends, we have started this series these days in the afternoon because from 9, I am also getting late to reach the home. By 9, I'm not able to reach. So usually our program was scheduled at 9, 9:30. So I thought we will do in the afternoon, but sometime what we are getting, we can leverage and do some knowledge sharing. So for this, today I am having the two stalwarts, Dr. Ragini Madam and Dr. Tiwari. I had done one session with Dr. Tiwari few days back only, which was highly appreciated by all. So today we are having once again Dr. Tiwari with us with a very important topic he is going to discuss with us. So I request to all of you, whatever the queries you are having, please do write in the chat box, and once his talk will be finished, we will take all that queries. So we are waiting for, yeah, I think Dr. Tiwari is joined here. So a warm welcome, Dr. Tiwari. I think he is joined.
Yes,
Saiti, once
ma'am.
he
Yes,
joined,
ma'am.
then
Yes,
once
ma'am.
he joined, then we will welcome him. बघितलं नाही. Dr. Tiwari, are you there? So she can introduce you. I think you can introduce Saiti. Meanwhile, as soon as he joins, we
Yes,
will
ma'am.
start.
So it's my privilege to introduce the speaker of today's webinar, Dr. Rajendra Tiwari, sir. Sir has done DNB, DGO, FCPS, DGF, LLB, PG, and DIP in HR. Joint Secretary, sir, is currently the Joint Secretary of IMA Maharashtra, MC member AMC Mumbai, ex-chairperson of ML Cell IMA MS, Secretary Palghar OBGY Society, executive member of IAEC Foxy, and sir has received numerous awards, including MMC Award in 2016, Bharat Jyoti Award, Jane Pataro Award, and Dr. C.L. Zaveri Award, and President Appreciation Award from IMA MS. So I welcome you, sir, and I hand over the session to you.
So warm welcome, Dr. Tiwari. Please, you can go ahead with your presentation as a lot of doctors have already joined on the YouTube. So we all are waiting eagerly to hear you. Thank you, dear Sahiti. Thank you so much.
Sir, I request you to please click on slideshow, which is on top, and then from beginning, slideshow. Yes, from beginning. Yes, sir. So we cannot hear you or see you, sir.
Yeah, now I'm audible. I'm sorry.
Yes, yes, sir.
I had not loaded the talk on the laptop, so there was some delay. Thank you at the outset. Thank you, Ritu madam, for giving me this opportunity again. And today's, I'm audible now, na?
Yes, sir. Yes, sir.
Yeah.
Perfect.
Thank you, ma'am, for giving this opportunity again to join with the elite club of yours. Today's presentation on interprofessional jousting is more of a message one has to give to our community, fraternity, than a presentation.
Very important topic, Dr. Tiwari. Very important topic because we
Yeah.
all want to listen on this.
Yeah, it's an important topic, and unfortunately, on this topic, much material is not available in any medical legal books or any forensic books anywhere. The material is not available.
You are yourself encyclopedia for the medical legal issues. Last time also you had done a rocking session.
Thank you, ma'am. Thank you.
Yeah,
So
yeah.
thanks a lot. But I have tried to give justice to the topic by searching material from different sources. Now I'll go by this is a game actually medieval Europe. They used to play a sports wherein the sports person used to ride on a horse and beat other sports person with lances. It was sort of violent game where they used to beat each other. The same game is the name of the game is now used for describing the rivalry among our colleagues. So the term jousting. Jousting actually is a French word which means fighting. So medical jousting is nothing but it is an uninformed criticism of our healthcare colleague. As I already told, it is a word from European countries, France word. Nowadays, few organizations as well as few institutes, they are using jousting as a term for keeping some competition among the doctors of their fraternity or कोई department है उसमें कोई doctors का healthy competition रखते हैं. They write competition, they keep competition like essay writing or writing on certain topic or some skill जैसा knot suturing है, suture से knot बांधना. इस टाइप के competitions रख के उसको भी jousting ऐसा नाम दिया जाता है so that this jousting should be healthy and competitive, should not be unhealthy competition. Now in this entire discussion of 20-25 minutes, I am going to speak about the scope of jousting. What are the different precursors and facilitators of jousting? What are the implications of jousting? Means what are the implications of we criticizing or downsizing our colleagues and how to prevent it? This will be the main headings under which I am going to cover this topic. Dear friends, as we all know, there is a scope, different scope for jousting, which has been, it can be a direct verbal, indirect verbal. It can be through body language without speaking anything. It can be by writing on the patient's record, or it can be written outside the patient records also. Now, direct verbal means what? How the patient किसी के पास चला गया, मेरा patient और किसी के पास चला गया. X का patient Y के पास चला गया, Y उसको बोलेगा, you should take legal actions against him, the doctor. The doctor has not treated you properly. Case कर दो उस पे. This is direct verbal. Indirect verbal is passing oblique comments. It is not direct. But I would not have done the things which Dr. XYZ has done. It means he is criticizing only, but it's an indirect way of speaking that he has not done the things appropriately. Another is body language. Body language mein to there is a signal. Doctor is not saying anything. Just he is making faces and using his body language to convey the message he has about the another doctor. Like वो file देखेगा, he will make surprise. He will make different faces, make language, body language in such a manner that without saying a word, he will convey his feeling to the relatives and the patient sitting in front of him about the doctor who has treated the patient previously. Written in the patient's record. Now, sometimes the doctor makes the entries in the record, case sheet of him about the other doctor. He had the previous doctor advise LACS cesarean section in the right time, the baby would have been saved. Like that, just I'm giving example. Such kind of notes can be written on the paper about the doctor. Another is written outside the patient record. Now it can be anywhere. This includes social media, जो कि अभी बहुत यूज भी किया जाता है और मिसयूज भी किया जाता है. Then social media reviews, website, messaging services. For example, Dr. X now, Dr. X, he was moron here in the medical college also. It seems now also he has not improved. So at least judging at what he has done to this patient now, I feel he has not improved now also. Such kind of writing such comments on social media or anywhere about the doctor outside the medical records. Now, what is the incidence of jousting? So that Dr. Ritu thought that this topic should be taken for discussion. That itself indicates that the incidence has increased. It was there, but it is increased because of doctors are increasing now. Yeah. Hello, ma'am.
I'm so sorry. I'm so sorry. I'm
Hey,
so
no
sorry.
problem. Yeah, no problem. I thought you were saying something. So incidence has drastically increased. It appears much more common than what one can imagine. The comments made about the other doctors were analyzed by a sting operation, and they were the analysis came out very shocking. It was found that 67% of the doctors were critical about their other colleagues. 29% of the doctors were supportive about their colleagues, and 4% fortunately they were neutral. They were not negative also or positive also. All who are from Maharashtra know this saint. He is respected Saint Tukaram Maharaj. He has said he has written great poetries, and he has said की निंदकाचे घर असावे शेजारी in Marathi. It means you should have a critic as a neighbor, because the critic आपको अगर वो criticize करेगा तो you have he according to him that criticism should be taken positively, and we can use the criticism as one of the modality for improving ourselves. ऐसा अपने मदर फादर टीचर्स, अपने को टीचर हिस्टेक्टोमी करते थे, रैडनिंगचा बराबर तूने कॉटराइज नहीं किया, कॉटरी सेटिंग बराबर नहीं रखा, दैट इज क्रिटिसिज्म ओनली, बट वो अपने सामने होता है, एंड द इंटेंशन ऑफ दैट क्रिटिसिज्म इज टू इम्प्रूव पीपल, नॉट टू डाउनसाइज देम. तो यही क्रिटिसिज्म जॉस्टिंग में क्या होता है, पीछे होता है, इट इज बिहाइंड द अनइन्फॉर्म क्रिटिसिज्म, इट इज बिहाइंड योर बैक और इट इज लाइक अ बैक बाइटिंग. Jousting may be unintentional many times, however, it can be intentional at times. Under stressful situation, it can be a defensive strategy also, wherein a blame game is initiated to shift the onus of the anticipated mishap to the other doctor. आजकल obstetric NICU, obstetrics intensive care बहुत सारे बढ़ गए हैं. Many times our patient of next door small nursing home owner gets complicated and he shifts that patient to the obstetric intensive care unit or to some higher center, wherein the receiving doctor thinks that this patient is as such sinking and the prognosis is not good. Tomorrow if the patient expires, we should make a background. So in order to save his own skin, he starts saying कि patient already sink हो चुका है, हाइपोटेंशन में है, एंटीबायोटिक दिया था क्या, पूरा सेप्टिसिमिया में है, वी डोंट नो वेदर विल सर्वाइव और नॉट. सच काइंड ऑफ सिनेरियो he creates so that he can save his own skin. Now, as I said, another topic is precursors and facilitators of jousting. There are various precursors. The list will be endless. It can be, exhaustive. But I have tried to cover few. The first and foremost precursor is jealousy and greed. काम क्रोध मद लोभ मोह ने तुझको कैसा घेरा, अनुप जलोटा बोलते थे. So काम क्रोध मद मोह लोभ, ये पांच अपने एनिमी है. Every human being has got that enemies. Doctor has come from society. Doctor has not fallen from the sky. He is a member of society. जो उसको society में जो problems है, that doctors will also face. So that should be handled appropriately. We should feeling jealous about the colleagues can give rise to such precursors which with which a person can indulge into jousting. Another is macromania. Macromania is fondly said for a feeling wherein a doctor thinks that he is the only qualified and skilled doctor and others are moron, or others are underqualified than him, or others are underskilled than him, and he is something superior than others. Such kind of feeling if you harbor, jousting can emerge out of such feeling. Economic progress is an important yardstick of success. Unfortunate but bitter truth. Because of that, everybody wants to grow, economically grow, and in that process, the jealousy comes and unnecessary such kind of things can happen out of our hands. A wrong notion that criticizing and downsizing our competitor will enhance our image in the patient's mind. That wrong notion can give rise to such kind of act. Intense and impractical craving for money. Our past medical IMA president always used to say in all the corridors of power that you are telling doctors loot rahe, doctors both kama rahe. Tell me one doctor who has an account in Swiss bank only on the basis of practice. Absolutely no doctor has. We are earning sufficient to live our life peacefully and graciously, but we are not earning by leaps and bounds. So there is no point making intense craving for money. A defensive strategy to shift onus to other doctor in case a medical legal problem arises or anticipated, as I already mentioned. Misunderstanding to the incomplete information about the prior treatment given by the relatives or by the patient himself or herself. Patient and relatives tend to forget major chunk of facts explained to them regarding the treatment plan given by the prior doctor. Therefore, relying on the information given by the patient can lead to misunderstanding by the next doctor. Many times, relatives and the patients, it has been established by various studies. If you go online, you will find studies. You will find various studies which have been established that the patients and the relatives, because they are under stress, they are doing only emotional listening. So they many a times, if you tell them 10 things, they will accept and remember only the things which suit to them. One patient I had told about os tightening, his cervix short hai, last prior abortion was there, but she told no, abhi मैं कर नहीं सकता. Wait for 8 days. We'll see. At present, it is not that risky, but you may require it. So she listened only the thing which suited to her. बाहर जाकर रिलेटिव बताती, डॉक्टर ने बोला अभी अच्छा है, टाका का जरूरत नहीं. So such kind of information is pursued and remembered by the patients and the relatives. So if we are making opinion about that doctor, prior doctor, depending upon the narration given by the patient or the relatives, it can go wrong. Now, how it is practiced? There are various means of practicing jousting. Many a times when I go to present this topic, I come out with different methodologies of jousting from the sitting doctors who gave me the ideas. Now I have just given mentioned few of the questions. Basically, questions which raise suspicion on the skill, efficacy, efficiency of the prior treating doctor are asked. और दे आर एक तो पूछा जाता है या तो ऐसी तरीके से कुछ योजना की जाती है जिससे दैट क्वेश्चंस विल बी ओवरहर्ड बाय द पेशेंट. Now such questions are few questions like why X-rays were not taken, especially orthopedicians. Why X-rays were not taken? See, this fracture is there. Had that orthopedician would have taken X-ray, now this fracture would have seen small, but it is significant fracture. He should have taken. Why blood investigations were not done? Workup nahi kiya. How he did surgery without working up? Did the doctor examine you thoroughly? ऑपरेट किया, एग्जामिन किया था कि हार्ट डिसीज लग रहा है, चेस्ट अच्छा नहीं, तो सच काइंड ऑफ कमेंट्स में भी पास. डिड द सर्जरी गो वेल? बराबर बाहर आया था ऑपरेशन थिएटर के, क्या प्रॉब्लम हो गया था, भागदौड़ हुई थी? व्हाई द पर्टिकुलर टाइप ऑफ एनेस्थेसिया प्रोसीजर वाज डन? वाज देयर कुछ अल्टरनेटिव था नहीं क्या? डिड द अटेंडिंग डॉक्टर टेक सेकंड ओपिनियन? वाज द डॉक्टर श्योर ऑफ डायग्नोसिस? ट्रीटमेंट किया, वाज द श्योर? आई डोंट थिंक सो. आई वुड हैव नॉट कम. सी, इफ यू वुड हैव कम टू मी ना, I would not have done like this. Your case has been spoiled. वाट लगा के रख दिया है, कुछ नहीं हो सकता. Nothing can be done now. Who gave this scar now? This big scar for hysterectomy in this era? अरे laparoscopy किया रहता, कहीं को इतना बड़ा scar किसने दिया ये scar? What implication it leads? Dear friends, such kind of comments or statements lead to implications. I am a part of negligence committee of Palghar district, and after helping so many colleagues in medical legal fields, I have come to the conclusion that many medical legal cases are filed only because some colleague has told some negative thing about our treating doctor. ये तो पेशेंट को इतना केस फाइल करने के लिए जो भी नॉलेज लगता है, बैकग्राउंड लगता है, वो लेमैन नहीं लिख सकता है. वो सब इंफॉर्मेशन कोई तो अपना ही नेक्स्ट डोर नेबर या अपना ही कोई कलीग उसको प्रोवाइड करता है, बिकाइंड आइडिया भी वही देता है. उसकी वजह से सच काइंड ऑफ मेडिको लीगल केसेस आर राइजिंग. So, वो तो medical legal तो ठीक है, it can lead to violence. Doctor can, that patient can come to the prior doctor and he can fight with that doctor, either verbal or even assault the doctor also. Doctor battering can occur. The jousting prompts the patient to file medical legal suit against the prior doctor, as he gets many ideas to blame the prior doctor due to the information provided by the another doctor. It lowers the strength of doctor-patient relationship. If cases increase, हर डॉक्टर में लिटिगेंट, हर पेशेंट में लिटिगेंट देखा जाता है, and because of that investigation बढ़ जाते हैं, and the prior healthy relation of doctor patient relationship was very healthy 20-30 years down the line. उस टाइम कोई को फीवर आ जाता तो मलेरिया का ट्रीटमेंट डॉक्टर डायरेक्ट प्रिस्क्राइब कर देता था. They never used to do investigations, patient ठीक भी हो जाता था. But now everybody is doing investigations. It is not bad to do investigations. I am not against that. But many a times patient may get over investigated and the cost of treatment may increase if such kind of jousting and lowering of doctor-patient relationship occurs. You might be knowing Kunal Shah versus Amri Hospital case, wherein 6 crore odd amount was awarded by the Supreme Court and the National Consumer Redressal Forum. नेशनल कंज्यूमर रिलेशन फोरम में पहले किया, सुप्रीम कोर्ट में उसको मंजूर कर दिया. 6 करोड़ जो डॉक्टर कुणाल शाह, the patient was a skin disease patient admitted in Calcutta. The patient was doctor and husband was doctor. Treating doctor had given prednisolone in very higher doses, alternate day he had given, and that patient became bad. After becoming bad, the patient was brought to Mumbai in some hospital, wherein some resident doctor told something about the prior treating doctor. उससे trigger हो गया, and that medical legal case was filed. Filed होने के बाद, you know what was the implication? 6 crore amount was awarded to the doctor and hospital, which is a very big amount, my dear friends. So such kind of implications can occur. Why they occur? Because our doctors, they fail to restrain themselves from making certain loose comments. Now, how to prevent it? Our fraternity members, WHO, and many of our senior learned colleagues have made various attempts right from the beginning to stop such backbiting among our colleagues. Even the NMC draft, which has been in place now, it has been already ready, but it has been postponed. It also mentions that we should not, chapter 33, section 13, if I am not wrong, that is mentioning how you should behave with your colleagues and how you should behave and speak in front of the patient of your another colleague. How you should appoint locum, what are the responsibilities of locum, how you should behave with the patient if it is a locum doctor. So all these things have been mentioned in the NMC draft also, and they are mentioned in the our prior Indian Medical Council or जो अभी Indian Medical Council Act अभी भी force में है because NMC Act has been postponed. जो guidelines है, though NMC is established now, the ethical guidelines of NMC are still not have been enforced. और जो IMC की इथिकल गाइडलाइंस एथिक्स रेगुलेटरी रूल्स 2002 वो अभी भी फोर्स में, उसमें भी मेंशन्ड हाउ टू बिहेव अबाउट द डॉक्टर एंड इट इज नॉट लाइक परमिटेड. डिस्कस द प्राइमरी डॉक्टर रादर देन द पेशेंट अबाउट द डिस्क्रिपेंसी नोटेड. स्मॉल टाउन है, अभी दुनिया बहुत छोटी है, सो पीपल नो ईच अदर, सो व्हाई नॉट टू कॉल द डॉक्टर एंड आस्क हिम क्या हुआ था rather than listening from the patient and making opinion. Discuss problems, complication with the patient in such a manner that it should not be offending to the physician. Avoid making any personal or professional comment about your colleague in front of any outsider for that matter. Forget about वो patient था नहीं था. नॉन मेडिको पॉपुलेशन अपने नॉन मेडिको फ्रेंड्स रहते हैं, कोई वकील, कोई लॉ लीडर्स, फिर रात में बैठा साथ में और कुछ दूसरे डॉक्टर के बारे में कमेंट, लूज कमेंट पास किया. दैट कैन ऑल्सो हार्म योर फ्रेटर्निटी. सिर्फ वो डॉक्टर को ही हार्म नहीं करेगा, इट विल हार्म अस ऑल्सो बिकॉज एवरीबडी इज सेलिंग इन द सेम बोट. If you make a hole in that boat, it is not that person who is going to sing, but even you are going to sing. United we stand. Now, as I already told, MCI guidelines are ethics regulatory guidelines are still in force. Section 4.2 relates to the conduct of consultation, which states that in consultation, no insincerity, rivalry, or envy should be indulged. If you do that and it gets proved, you can be suspended temporarily from the MMC on this basis. Is a violation of guideline. All due respect should be observed toward the physician in charge, and no statement and remarks be made which could impair the confidence reposed by the patient on him. The one who is criticizing may come under legal hassles. The departments and institutes in the corporate should set up a mechanism to tackle jousting. While referring a patient, notes should be in detail so that he can make an idea depending upon the notes. Writing mail to the prior doctor is also one of the idea, but how it works in our countries, this has been taken from the South African guidelines of Medical Legal Society. Medical teachers should teach and mold their students about the jousting and negative implications of jousting should be explained to the student by the medical teachers, professors, head of departments, unit heads, etc. Now I'll give to just two case scenarios and then I'll end my topic. Case scenario 1 is Dr. A operates on the patient. It is a very simple scenario. Wound gap occurs. डॉक्टर ये उसका ड्रेसिंग करता है, पेशेंट भी थक जाता है, पेशेंट गोज टू डॉक्टर बी. डॉक्टर बी इंस्टेड ऑफ फोकसिंग ऑन द ट्रीटमेंट tries to pollute the mind of the patient. He tries to convince the patient that he did grave mistake by consulting the Dr. A, and Dr. B further informs the patient that Dr. A does not have sufficient skill and knowledge due to which his patient gets complicated. उसको कुछ नहीं आता है, इसकी वजह से उसका पेशेंट ऐसे ही हमेशा होता है, मेरे पास ही ड्रेसिंग के लिए आता है. The patient gets treated by Dr. B. The wound heals, but the patient is left with deep grudge against the patient, Dr. A. Case scenario, some doctors tell the patient that their surgery is incompletely done. There was a case wherein a subtotal hysterectomy was done of an obese, hypothyroid and diabetic patient, unmarried patient she was, old but unmarried, and uska subtotal was done informing the patient, both agreed, so doctor did. Later on, subtotal was written that was misconstrued by the patient and instigated by another doctor as incomplete surgery. That afterward surgeries are. And that also created problem for the doctor, though not that case was not like it doesn't stood in the consumer or any forum, लेकिन headache तो हो जाता है, harassment हो जाती है. Doctor may make serious face while going through the patient's file, or he can throw the file or make gestures which will convey dissatisfaction and objection to the prior treatment. Some angry old doctors or angry young doctors, angry old doctors be angry रहते हैं, they behave like angry young man, and they throw away the colleague's file and shout on the patient for going to the wrong doctor, which is not uncommon. A doctor discussing with the RMO or associate, look, this patient has also wrongly been treated by the doctor, just the way that a prior patient Sangeeta, poor chaps, these patients don't know that how that doctor is unnecessary, they get duped. Such kind of statement made to a colleague in front of that patient or relative, so overheard by them, and that can also create misunderstanding. Few doctors are even more shrewd. They do not utter a word. I said already, they just make a body language. Small nursing homes sometimes need to transfer patient to the higher center, which I already told. There also, if somebody makes some comment, like, where did you treat the patient? Is the doctor qualified? Has that totally spoiled the case? Sorry, but case has been spoiled. Worst one can even tell the patient or relative to teach the doctor a lesson ऐसा भी कहा जाता है कभी कभी. And some doctors may, or some colleagues of us, unfortunately, they may stoop as low as to instigate the patient playing caste, religion, community, ethnicity card. Now there are different schools of thought. There is something known as Bolam's rule in our medical legal parlance. Bolam was a patient. How that rule come into place, many of us might be knowing. But Bolam was a patient who was admitted in a psychiatric ward in UK, wherein ECT was given without giving anesthesia. Because of that, he got cured, but उसको fracture हो गया ट्रोकेंट्रिक, और ट्रोकेंट्रिक फ्रैक्चर होने की वजह से इमोबिलाइज हो गया, और उसने केस किया हॉस्पिटल एडमिनिस्ट्रेशन में. तो since two schools of thought existed, some doctors believe that giving anesthesia is a better idea. Some doctors believe that without sedation also it can be done. But two schools of thoughts were there. Isliye court acquitted the hospital, and no compensation was awarded. So there can be two schools of thought regarding any kind of treatment. What the doctor has done might not be acceptable to you according to your thoughts, but one has a way to say, only because he has not followed your school of thought, he never becomes a bad guy, or he doesn't become a bad doctor. Sheer criticism with the intention of showing some person down using derogatory or filthy language is not acceptable. Yellow journalism is not welcome, but unfortunately, yellow journalism has become very common nowadays. There are black sheep, as I told, everywhere. Doctor comes from the society from where the other people come. There might be situation that we come across Dr. B doing some unethical things, but they can be managed very differently also through associations, through our organizations. To conclude, as I already told, everybody is selling in the same boat. प्रोफेशनल जॉस्टिंग इज अ क्रिमिनल ऑफेंस इन मेनी कंट्रीज. इवन हियर ऑल्सो अगर किसी ने रिकॉर्ड कर लिया 1447 है, तुम्हारा डिफेमेशन है, ये सब केसेस अपने पे बैठ सकते हैं. अगर कोई डॉक्टर ने रिकॉर्ड कर लिया तो ही कैन फाइल अ केस अगेंस्ट अस. एंड डॉक्टर इन सम कंट्रीज इवन अ प्रोफेशनल जॉस्टिंग इज अ different sections are there of criminal code. Doctors like Dr. B should learn that it would be far better to prove his supremacy through hard work, sincerity, transparency, give better to the patient. अपनी लाइन बढ़ाओ, दूसरे की लाइन कम मत करो. By that way also one can prove that you are superior. So use your pen righteously. Believe me, it's mightier than sword. It will not only shield you, but help the nation to grow. Thank you very much, madam.
Thank you, Dr. Tiwari, for such a comprehensive lecture. You have covered all the points, and I'm able to see Ragini madam. Warm welcome, Ragini madam.
Welcome, ma'am.
Yeah, thank you for joining. So, as Dr. Tiwari, if you want, you can continue. Otherwise, after madam's lecture, whatever the questions we will receive, we will take
Let
that.
madam finish the lecture.
Yeah. Saiti, please introduce madam. Please, madam, we are giving you a short introduction as lot of doctors are waiting on the YouTube to listen you. A very interesting topic, and thank you, madam, for taking out time from your busy schedule. Yeah, please introduce Saiti.
Yes, ma'am. It's my privilege to introduce Dr. Ragini Agarwal, ma'am. Ma'am has done MS, FICOG, FICMS, CMCH, and Director of AA Derma Science, Complete Clinic for Women Health, and Director, Department of OBGYN, Cloud9 Hospital. Ma'am is the founder and president of Indian Society of Aesthetic and Regenerative Gynecology, founder and president, Indian Academy of Cosmetic Dermatology and Gynecology.
Thank you, dear. Thank you.
Ma'am is also the past vice president of Foxy. So with this short introduction, I hand over the session to ma'am.
Thank you so much. Thank you, Ritu, for giving me this opportunity and wonderful way of handling the session. And I have heard Dr. Tiwari also. It's really wonderful to listen anyone on the medical legal front.
Warm welcome, madam. Warm welcome. Ma'am, though the audience is less here, most of the doctors join via YouTube. So we will get, last time only I had done the session with Dr. Tiwari. We got a bombardment of the questions. So I requested him, please come, because he's the first doctor who has come in my session within the time period of the 15 days. We got a bombardment of questions for Dr. Tiwari. Very highly appreciated by all. So warm welcome to you, madam. Warm welcome once again.
So thank you, Ritu. My topic is little different. Although we are all talking about the female sexual function, which is a matter of quality of life. And until unless we face it and try to really handle it, it is not being discussed. And it is a topic which is literally behind closed door. But as a clinician, and the women health specialist, it is our duty to raise the voice, and we have to talk about the sexual dysfunction. Sexual behavior, the composite of the physiologic and anatomic and the psychosocial factors, is unique in every individual. Therefore, no one definition of the sexual behavior is universally accepted. There are lots of cultural restriction when we talk about the female sexual dysfunction, and mostly it is considered something not a day-to-day thing, but something really organic or something like that. And it is very even difficult to understand the path of the sexual dysfunction in the woman. But it is really important for maintaining overall physical and mental health. And it is imperative to public health as a marker of health quality. You all know that the sexual activity reduces stress, regularizes sleep cycle, and regulation of our mental well-being as a whole. These all things reduce if there's a sexual dysfunction. So it is imperative to talk about it, and there are many types of the sexual dysfunction. For that, we have to understand the regular cycle. And why I am talking about these things when I have to talk about the vagina dialogue. Everybody is thinking what I'm going to talk about the vagina dialogue. So basically, we all know that vagina is the main sexual organ in a female. And female sexual response is more accurately described by a circular model which has a many feedback points. And it is a vital part of the being from which she can derive pleasure, confidence, intimacy, and the motherhood also. And its diagnosis is ascertained by taking a thorough sexual history because there are no objective measures. Disorder is directly as a part of the sexual response cycle, and they flow in each other. If anything is there, another point of the disorder will start. So when we talk about the silent suffering of the woman, what we talk? We talk of the vaginal laxity, we talk about the dyspareunia, we talk about the vaginismus, we talk about the genitourinary syndrome of menopause, we talk about the anorgasmia, and we talk about the vaginal infection, vulval infection. So all the problem of her silent suffering, which result in a sexual dysfunction, is a part of a vaginal problem. So it is very imperative to understand the woman problems in a vagina, and it is the most important organ for the normal sexual health. So this is the vaginal dialogue which I want to discuss today with here. So why vaginal health is so important? As we know that it can affect fertility, desire for sex, ability to reach the orgasm. Ongoing vaginal health issues can also cause stress or relationship problems and affect self-confidence. So foremost, I want to discuss about the vaginal laxity, which is a problem many women suffer silently, or they go to the doctors and many times there is no answer, or gynecologist is not sensitive to address this problem. It is defined as looseness of the vaginal opening, which differs from the pelvic organ prolapse, which is the descent of one or more genitopelvic structure. Relatively common complaint, a survey of the Ayuga physician reported that over 80% of the patient underreported vaginal laxity. And as aging progresses, reduction in the vaginal wall elasticity and lubrication are common. Subsequently, sensation during intercourse is decreased and vaginal dryness or irritation occurs. This syndrome either present as a symptoms of the sexual function in form of arousal, orgasm, or satisfaction, or psychological symptoms like loss of femininity, loss of sensuality, decreased sexual function. Then it is now considered with after the POPQ classification, we all know it starts with the vaginal hiatus. And when we talk about the vaginal laxity, we are talking about the lax vaginal hiatus. So it might be a 0 first start of the POP. Patient can complain of a symptom of pelvic organ support like dragging, SUI, OAB, or there's a vaginal symptoms like irritation, dryness, recurrent infections, and vaginal flatulence. This is a very common problem. Patient after normal delivery, we all know there is a laxity, and specifically if we don't repair properly the episiotomy and don't offer a pelvic physiotherapy to that woman is going to end up with the vaginal looseness, specifically if it is a difficult vaginal birth or assisted instrumental vaginal birth, which mostly manifests when the patient after 40 plus, the hormones are decreased and she develops the laxity more and more. So today we have many treatments for this problem. The most important thing is awareness among the clinician and awareness among the patient. Today's woman is independent, she is aware, she wants her own sexuality to be addressed. And as a clinician, not only we have become aware, we have become sensitive, we have many tools in our hand. Long back, what we have to offer? Only a vaginoperineoplasty. And believe me, friends, if you have done a normal delivery and you properly applied the episiotomy and corrected the perineum at that time, most of the women is not going to come early with this vaginal problem. And we never thought that this vaginal laxity itself causes lots of the marital discord, which leads to the decreased quality of life and affect the mental health and the self-esteem of the woman. So what is vaginoplasty? When we talk about the vaginoplasty, it is colpoperineorrhaphy, which we are doing since ages. But here we have to focus more on the perineoplasty. So there is a base on your repair and it is go in a long way. It does not mean that you have to tighten it like that it causes too much of the iatrogenic dyspareunia or you change the angle of the vaginal axis. So these two things are very important during the vaginoplasty. And second thing, with the advent of the energy-based devices, which comes in the market, we have to understand every case of the vaginal looseness is not going to be treated with the energy-based devices. Maybe it is laser or HIFU or radio frequency. Yes, they can play a small role, but we have to add many adjuvants when we talk about the non-surgical vaginal tightening. Here we use threads which are basically introduced for the face lift. Here we apply those threads and those thread causes a constriction, fibrosis in the vaginal canal. And not only this, they cause a regeneration of the area mucosa also. In some cases, we introduce the PRP also. And today, every doctor is too much aware of the use of the platelet plasma, which is being used in all specialty for the regeneration because of its own so many growth factor is in the PRP. Not only the aesthetic gynecology, in the reproductive medicine, in the urogynecology, and other department like ortho, dentistry, everywhere the PRP is being used. But believe me, the first and the foremost important thing is a pelvic exercise. If you put your patient on the pelvic exercise antenatally and advise pelvic exercise postnatally, even when you do the vaginoplasty, you advise your patient the pelvic exercise because what you need is a strong muscles. We all know that the pelvic floor has a muscles which are very small muscles, and here if those muscles are strong, only then that vaginoplasty is going to give a better results. The second important thing, which is when we talk about the vagina dialogue, is a vaginismus. What is vaginismus? Vaginismus is a persistent and involuntary spasm of the perineal muscles which close the vagina, and today vaginismus is called as a levator ani syndrome. It is a condition that affects a woman's ability to engage in any form of the vaginal penetration. Even in many patients, they are even unable to put a tampon or a insertion of a menstrual cup also. And even in the real cases, it is very, very difficult to do the gynecological examination. When a patient of the business must come to in your OPD, you have to be very compassionate. Listen her and don't say that it is not something which is only in her head. Yes, maybe there's a psychological trauma leading to business, but she has every right to have a normal sexual life. She has every right to live like a normal person. So addressing this problem is very important. A detailed history is very, very important. And most of the patient, if it is a grade 2 or grade 3 or grade 4, it is very difficult to examine those patients. Many times these vaginismus is not only after many, many sexual therapies and psychotherapy, patient is not improved. And if woman herself is ready to cooperate, so these patient should be taken up for the further thing. With the advent of the introduction of the Botox in the vaginal area, in the levator ani muscle and the puborectalis, the work has become very easy. Because when we insert the Botox leads to the paralysis of these muscles, which is there for 3 to 6 months. And in that time, the woman is advised to have an intercourse. She has no pain, and the central sensitization which occur in the her brain, and the signal goes that no, this is not a painful procedure. Almost 90% patient, they never require another treatment. A very small patient, usually these are the patient who has a some childhood abuse or a trauma, they are not get corrected completely. So those treatment which are there like vaginal dilatation and the exercise, these really don't play much role. When we give the Botox to these women, there are two things which very important to tell them. One thing is that might be, although it never happened, that patient can lead to a involuntary uh, leakage of the urine or the feces if the muscles of the urethral sphincter or the anal sphincter is paralyzed. Therapy should involve the partner, that is a must, and gradually include more intimate contacts. One of my patients, she says, no, me and my husband will gradually want to try by ourselves. And now they are progressed to the smallest dilator to the third dilator by themselves. So many think this therapy, your compassion, and if the couple really want to do it, they can really go ahead and can get the treatment for the vaginismus. But in the most of the patient, the Botox is a very good answer for this levator ani syndrome. Now, the third thing which has come when we talk about the vagina dialogue is a menopause. Today, with the longevity in the woman, woman lives almost 20 to 30 years of her adult life in postmenopausal era. And in contemporary time, when she is sexually active, many a time divorces are there, late marriages there, and not only this, there is cancers. Even younger girls, they are getting cancers, get treated by the chemotherapy and the radiotherapy, and they have a iatrogenic menopause. And we all know that POI is increasing. These women who has a premature ovarian insufficiency, they also develop a menopause-like problems. So in these patients, again, they come to you with the problem of the vaginal dryness, atrophy, and unable to have a sexual intercourse. Maybe it is a reduced vaginal reserve, reduced number of the gonadotropin responsive follicle, and in the menopause period, we all know there's a attenuation of the urogenital epithelium. So how does menopause affect sex life? maybe because of these things, or menopausal problem like insomnia, irritability, altered skin sensitivity, and the hot flushes. There are many comorbidities also and social taboos also. Older women and the sexual dysfunction is a point of discussion because women's perception of herself as a sexual being is the most important thing. As women lose the ability to procreate, they may be viewed as asexual and are not expected to desire or enjoy sex. This image is further perpetuated by society, viewing the elderly as a functional children, an attitude that strips them of their sexuality. The issues which arises is the most common is a HSDD or the desire. Then this hypoactive desire syndrome leads to the arousal because of the less of the glycogen and the vulvovaginal atrophy. There's a lack of the lubrication, dryness, and there's a pain. And this it start with a cycle and goes on and on. So this symptomatic vulvovaginal atrophy we know is because of the hypoestrogenism. Estrogen is having a vasodilator effect, and vagina, urethra, vulva, they're all affected, and there's a thin, pale, dry vagina in the vulval surface. It is highly prevalent in the midlife and the menopause, and this dyspareunia leads to decreased interest and the frank avoidance of the sexual activity. There's a many studies which has said that 63% of the women with VVA reported symptoms interfered with enjoying sex, and it also affected with their relationship with their partners. We all know that the estrogen, local application of the estrogen is no doubt is a golden choice. But sometimes a patient is hesitant to have, and maybe we can start with the non-hormonal lubricants or the moisturizer to provide the temporary relief, and may be sufficient for the patient if there is only mild symptoms. Phosphine is not available in India, but this is one drug which is FDA and the European Drug Association approved. And for the moderate to severe dyspareunia associated with the vulvovaginal atrophy, 1 year safety data is no endometrial cancer or hyperplasia, venous thromboembolism. But why should we discuss when we don't have this drug in our kitty in India? Carbon dioxide laser therapy is coming up in a big way. Even now we have many papers, even IUGA and NAMS, that is North American Menopause Society, is also giving their treatment. That vaginal laser treatment resulted in both statistically and the clinically significant improvement in the GSM symptoms. But when these patient has to come, we should have one questionnaire before and after. We usually use FSFI, which is available on the net, and you can download from there. It is a big questionnaire. You can shorten it according to your need and give to your patient when they are sitting in the your OPD, and they can have this thing. Coming to the next part, which is really a very, very common thing in our OPD. Every second or third patient is coming with the vaginal infections, and they are the most common gynecological diseases and one of the causes of the sexual dysfunction. We all know it may be fungal, it may be bacterial vaginosis, maybe trichomonas. And Candida group, the most important sexual dysfunction was related to the desire component. It is found in one survey. In more than 50% of patients, sexual dysfunction is twice as common because there's an irritation, there's a discharge, there's a pain, there's a smell. So it is very, very difficult to have a sexual encounter. Even if a patient are not using the condom, this problem can cause the infection in the partner also. And in today's society, with the increased promiscuity, premarital sex, the STI and the sexual dysfunction is also, we have to talk about the sexual transmitted diseases. It is a widespread infection like chlamydia, gonorrhea, syphilis, genital herpes, HPV, hepatitis B, trichomonasis. The list is unending. Psychologically, the Impact of an STI on a woman may be enormous because she may have a fear of contaminating her partner and her unborn children and lead to a diminished desire to engage in sexual intercourse. Women with STI should be counseled on how to have a safe sex and to discuss any emotion or fears they may be feeling about sex. Then, never forget Mullerian abnormalities of the vagina, which can lead to dyspareunia. Maybe there's an absent vagina, vaginal symptoms, or hemivagina, or what we call Ochvira syndrome. And here, patient has really unable to have a intercourse, and it is really very painful and leads to non-consummation of the marriage or a severe dyspareunia. Today we have patient coming with anorgasmia or other things. We have many pleasure enhancement vaginal shots for these patients also. G-spot augmentation with the fillers, or we give the PRP in the anterior vaginal wall, clitoris, labia, and vestibule, and it enhances their sexual pleasure. And agents are used, either hyaluronic acid or the PRP. There's a erogenous external genital structure in women, include the clitoris, labia majora and minora, vaginal introitus, and the perianal area. Densely innervated and a highly sensitive clitoris is extremely important, and arousal proceeds more readily and orgasm are strongest when the clitoris is stimulated. We should remember that there is a vaginal complex and sometimes there's a clitoral complex. Many women does not have any nerves in the vagina, and for them the pleasure and the orgasm is only because of the clitoris. So this high-tech intimacy, when we talk about the tackling the female sexual dysfunction, there's many devices also in the market like Eros, which can be used with the for the clitoral stimulation. So it has given the birth of the aesthetic, functional, and regenerative gynecology because of the end users' awareness, energy-based devices, adjuvants, and the most important is the woman independence and the physician understanding and the training. So, my dear friends, we should not be like an ostrich. And we should tell our patient that if you suffer from sexual dysfunction, you are not alone. We need to be open and adventurous. To do so is to admit to failing of the sexual desire. Because even if you're not leading the sort of sexually adventurous life, women are supposed to be living right now. And you should still be able to experience excellent sexual pleasure. Female sexual health matters, and we have to address it properly. And vagina is one of the most important sexual health organ which should be respected, and we should take ample help to have a proper vaginal health. So sex evolves through life, and that this is normal, and sexual intimacy is a basic human drive and essential to well-being. Thank you so much for patient hearing, and thank you, Ritu, for giving me this opportunity to discuss.
Thank you, madam. Thank you for such a wonderful lecture. Sahiti, you can go through. If there are any questions, please take. Ma'am, on the YouTube, we have received only the appreciations for both of you, for Dr. Tiwari and for Dr. Ragini, madam. Dr. Tiwari, for you, one question I received yesterday from Dr. Reshma Junjunwala. I think if you remember last time, she also joined from Sikkim.
Yeah.
So she last time, she just dropped me message yesterday only when I posted the flyer in the groups that so many pharma companies are approaching her to become as a medical advisor. So, and she's a very roaring practitioner in the Sikkim. Huh? So she wants that she can go ahead, and she is 38 years. On the Insta, she is having around more than 60K followers. Huh? So she want to ask that she can go ahead for that or not.
As per new NMC draft, she cannot unless she has been enrolled as an employee or advisor, and she's on the payroll for that, on that company's register.
Okay.
Directly, we cannot advertise any drug. We can advertise the drug, but not a brand name. As I already told, as per previous IMC regulations also, I had given the example of Sriram Lagu, who was
Yeah,
a
yeah.
popular actor. He is, in fact, I don't know whether he
Yeah.
he was a medical doctor, but he used to advertise Anacin that time. So his
Okay.
medical registration was suspended for 2 years by MMC. So if you
Okay.
advertise under brand name, it is definitely not allowed. For advertising certain drugs, okay, she can do, and she can advertise the brand name also if she is under payroll of that company and it has been established. The relationship of advisor is established.
Okay. Okay. Thank you so much. I don't think any more questions we have received today. I think both the talks are extremely good and covered all the points. So I think we will wind up with that. So thank you, Ragini madam, and thank you, Dr. Tiwari. Thanks a
Thank you,
lot
madam.
for
Thank you.
thank
for the
you.
opportunity.
Thank you so much.
Bye bye.
Bye. Thank you,
Bye.
Sahiti.
Thank you, ma'am.